the distinct pleasure of introducing Dr. Elise Davis. I met Elise over 15 years ago because I was interested in population health, health disparities, and impact on children with cerebral palsy. Elise is the Jack Brockhoff, in the Jack Brockhoff Child Health and Wellbeing program at the University of Melbourne. Melbourne is to Australia what the University of Chicago is to the United States. She has worked extensively both with vulnerable populations, including children with disabilities, adults with disabilities, and their caregivers. The title of her talk today is Measuring the Quality of Life of Children with Disability and Supporting the Mental Health of Parents. Elise.
Thank you, Mike, and thank you everyone for the opportunity to be here today. Can you hear me? Can you understand me? I'll try and speak slowly. So today I'm covering two topics. One is around the quality of life, how we measure the quality of life of children with a disability. And most of our work here is focused on children with cerebral palsy. And then also a newer area, which we're really trying to build some capacity in, which is around supporting the mental health of parents or carers of children with a disability. So what I'm hoping to cover today is to give some background on how we measure the quality of life of children, and particularly children with disabilities. Provide a guide into how we can choose a quality of life instrument for children with a disability. Talk about the instruments we've developed, so a cerebral palsy quality of life questionnaire for children and adolescents, and some new developments in this area. And then talk about some new research in terms of supporting the mental health of parents of children with a disability. And hopefully, if there's time, we have a short film that we've developed, just a 7-minute film to give you insight into the lives of parents, so hopefully we'll be able to show that. So what is quality of life? I would imagine everyone in this room can define quality of life and has their own definition of quality of life, but this is the definition of the World Health Organization, and clearly the most cited definition. So it's an individual's perception of their position in life, in the context of the culture and value systems in which they live, and in relation to their goals, expectations, standards and concerns. And whilst this definition is clearly very comprehensive, it's also very difficult to measure. And so we set about with the task of trying to measure quality of life. So we have a more operationalisable definition, which refers to an assessment of wellbeing across the areas of life that are important for that particular population group. So why is measuring children's quality of life important? The thing about quality of life is it captures an individual's perspective. So for children with a disability, it actually captures their voice. It's useful for evaluation and monitoring, particularly around evaluation of interventions and programs, quality improvement for service providers. It's useful for clinical practice. We can actually encourage clinicians to look at areas of a child's life that they may not typically look at. Useful to start conversations where you identify that there are potential issues, and useful to inform interventions, because often when we develop a quality of life tool, we start by talking to children and asking them what's important to their life, and so that's a good guide for us to then shape interventions to match that. And quality of life is really important to families, we know this. So this is Alan Culver, a researcher in the UK. The most important thing to remember is that when a child is born, a child is a child first to his or her family. It is his well-being, not his disability, which affects all of our everyday lives. And that's from a mother. So in terms of quality of life instruments, there's two major types of instruments: condition-specific instruments or generic instruments. So condition-specific instruments, such as our one to measure the quality of life of children with cerebral palsy, they're useful to detect changes in quality of life and are often used for evaluating interventions. And generic instruments theoretically should be applicable to everyone, every child, but are often useful when you're either a service provider trying to measure the quality of life of children with different conditions, And so what we know is that there's been quite a few systematic reviews, and this area has really expanded recently. And so we now have about 30 generic instruments for children and 64 condition-specific instruments. And whilst this is fantastic in terms of its development, it also makes it really difficult then for service providers and clinicians to choose a tool. And the tools vary a lot as well, so the decision is important. The challenge, I think, with measuring the quality of life of children is, as I said before, it's an individual's perception. And so self-report is essential. But for children, particularly children with a disability, we know that their ability to self-report can be dependent on their age, developmental status, intellectual ability and communication skills. So for children, we know that parent report can provide additional insights into a child's life. Parents are often making healthcare decisions for their children, and so it makes sense to also have parent report. The thing with child and parent report is they're not strongly correlated. They tend to be weakly correlated. So particularly for children with a disability, children tend to be much more positive about their quality of life than their parents. And I think that's kind of not surprising. It's very hard to put yourself into someone else's shoes and estimate what their quality of life is. So really the consensus in the child paediatric area is that ideally you'd measure the quality of life from both a child's self-report and a parent perspective. But they won't be the same, and that's fine, but both are important and considered separate. So we have a partnership with Urella. So Urella is a big service provider in Victoria. They offer services to children and adolescents and adults with disabilities. So we've partnered with them to develop and trial a new model of care. And the reason why they're interested in doing this with us is that we have a new funding model in Australia. So I don't know whether anyone has heard of the National Disability Insurance Scheme, but essentially it's an individualised funding model. And so whereas typically up until this point the government would provide funding to service providers, and then families would go to service providers to access the support they need. It's now changing so that the funding goes directly to the families, and then they can choose which service provider they go to. It only started rolling out in July this year, so we're really kind of in very early days, but it is designed to give families more control and more choice, which works as long as there are enough services within that area. So for some areas we know it probably won't make too much difference in terms of where they get their services. But it means, like for this project, Urella was really keen to partner with us because they actually want to make sure they're doing what families want and that they're meeting the needs of families. So this is, a really exciting project. One of the things that they're wanting to do as part of this project is to measure the quality of life of children and their carers, and to do this regularly as part of their evaluation. And quality of life would also be an outcome measure of, this is a randomised control trial, would also be an outcome measure of the trial. And so for us, we have started thinking about, well, what quality of life instrument would we choose, knowing that it needs to be something that's relevant across children with all different disabilities and ages. So we were left with these questions. How do we measure the quality of life of children with a disability? And what are the best quality of life instruments for service providers to use? So the aim of our study was to conduct a review to identify the best instruments for service providers to measure the quality of life of children with a disability. And so what we did in partnership with our service provider was to develop some criteria around what they think is important for a quality of life tool. So, and it's a unique perspective and perhaps different if you're using a quality of life tool as a researcher. So it needs to be a generic instrument. As I said, it needs to be applicable for children with all different disabilities. Obviously it needs to be reliable and valid and sensitive to change, and I'll talk a bit more about that later, but sensitivity to change is a major issue with quality of life, and there's lots of questions around whether you can actually change someone's quality of life. Because obviously self-report is essential, it needs to be potentially able to be completed by a child with a disability if they can. Obviously money is a big issue, so it needs to be short and not cost a lot for clinicians to be able to implement it. And service providers also work and make sure that their practices are consistent with the conventions on the rights of persons with disability. And this hasn't really been applied to quality of life measurement before, so this was something we wanted to explore. So I'm not sure how much everyone here knows about the Convention on the Rights of Persons.
We don't sign
these
international laws in this country because there are certain political parties who believe that if we advocate for rights, somebody may tell us when we're wrong.
So
don't go there.
Okay, so Australia has signed it.
No, but we're glad. We want to hear people who play by rules.
So it's an international human rights treaty. It states that all persons should have the same rights, respect for their inherent dignity and individual autonomy. So for us, it's a vital framework for creating our legislation and policies. And as I said, we really want to look at how we could look at whether it aligns with quality of life instruments for children with a disability. So I've just chosen a couple of articles to just kind of show how we're looking at this alignment. So Article 7, so children with disabilities have the right to express their views freely on all matters affecting them, their views being given due weight in accordance with their age and maturity on an equal basis with other children, and to be provided with disability and age-appropriate assistance to realise that right. So if we look at how this one applies to a quality of life tool, obviously it needs to have a self-report version, so children can express their views, but it also, the actual tool needs to be based on the perspective of children. So rather than a group of health professionals sitting around deciding what they think the important domains are for children. And then the other one that's relevant is Article 24. So persons with disabilities have the right to the enjoyment of the highest attainable standard of health without discrimination on the basis of disability. And this is a really interesting one because when we look at quality of life instruments, they quite often measure what we would term as functioning. So looking at what a child can do rather than how a child feels. And so it means that if a child has a significant physical impairment, they should still be able to report high quality of life if it exists. And if the quality of life instrument, though, is really assessing functioning rather than well-being, it can often be very hard for them and very hard for that tool to capture high quality of life. So these are some examples of some items from some quality of life tools. So it is hard for me to walk more than one block, or I miss school to go to the doctor's or hospital, or I forget things. So more around functioning rather than how a child feels. So what we did was looked at quality of life instruments and developed these criteria. So we looked at whether they're reliable and valid, whether it's been used by children with a disability previously, whether it looks like it would be able to be completed by a child with a disability, so short, single items, easy response scales, particularly for a child with a mild intellectual disability. Looking at whether the instrument is free, whether it's short, whether it was developed in consultation with children and parents, whether there's a self-report version, and whether the items measure functioning or well-being. So these were all the things that we then rated the generic quality of life tools on. So we identified generic quality of life instruments from existing systematic reviews because there's quite a few of them. So as I said, there was 30 instruments, but when we actually went through the instruments, a lot of instruments are used as quality of life tools, but they're actually functioning tools or health tools. So we excluded those and we ended up with 19 instruments that were actually designed to measure quality of life. And then we looked at them against the criteria. So what we found was that most instruments have acceptable reliability and validity, but only a couple have been assessed for sensitivity to change. And as I said, this is one of the big issues. So there's 3 instruments there that were assessed for sensitivity to change, but it's only kind of one intervention study they've been used in. So we certainly need to do a lot more around that. In terms of whether children were involved in developing the instruments, we found 11 out of the 19 instruments were based on consultation with children and or parents, and therefore actually measuring the domains that are important to children and parents. And we found that 11 instruments focused on measuring wellbeing, and so they use these kind of items. How do you feel about, or look at the extent of agreement with a statement like I feel good about myself. But the remaining 9 instruments were focused on functioning. And so how much of a problem has this been? Have you had difficulty with walking? So making it very hard for someone who has a physical impairment to be able to score high quality of life. Whether they were able to be completed by a child with a disability. So we found that 9 of the instruments seemed like they would. They were short in length, had simple questions and rating scales. But others, some of them were very complex, where they have 3 parts to every question, and you have to think within the last 2 weeks, and cognitively quite challenging. So we ended up, from all of that, with 2 instruments that we could choose from that met all the criteria. So they were consistent with a rights-based approach. They actually measure wellbeing. They have both child and parent report based on perspective of children and parents. They're low cost, reliable and valid. Some evidence of sensitivity to change. Short, simple items and response scales. So that's the Kindle and Kidscreen. I'll just quickly walk you through them. So the Kindle is a German quality of life instrument developed by Professor Ulrike and Raven Sabira. And there's 2 versions of the Kindle, so a 12 and a 24, and you can see the types of domains that they're measuring. Both of these actually are really focused on kind of physical, social, emotional wellbeing. And then the Kidscreen, which is a much bigger, probably more highly used questionnaire. So it was developed across 8 European countries and has a 10, 27, 52 items. So Kidscreen actually probably hasn't been used that much outside of Europe. I don't know whether it's been used in the US. We've used it a little bit in Australia, but obviously keen to use it more following this review. But there are obvious limitations. So these are generic tools, and so theoretically they should be applicable for all children, but we really need to pilot these questions with children with disabilities to see if they're appropriate. And the domains, as I said, although they were based on interviews with children and parents, they weren't necessarily children with disabilities. And so it kind of begs the question whether the domains of quality of life are the same for children with disabilities as children without. And there's lots of debate about this, because obviously theoretically areas of life should be the same for all children, but practically we often find there are some differences. And also thinking about the applicability of a generic instrument for a child with an intellectual disability, and then obviously if we're looking at moderate or severe intellectual disability, whether the domains are still relevant. So another project that we're working on is around actually measuring the quality of life of children with intellectual disability, because this is a really neglected area. So this is led by a colleague, Dr. Jenny Downs, and team in Western Australia. And so this is like a 3-year project where they're focusing on developing a quality of life tool for children who have intellectual disability and then there's these 4 groups, so cerebral palsy, autism, Rett syndrome and Down syndrome. And that what they have done, so most of these children are unable to self-report using our current methods. So they have, at the moment, focused on interviewing parents around what influences the quality of life for these children. But the next stage is always to then try to talk to children, particularly children with a more mild intellectual disability that we can communicate with. So from the interviews, these are the domains that are coming out as being important. So very similar to a lot of quality of life instruments. I think probably what are some new domains are around stability of daily routines, which I think you can understand why that would be important for children with a disability, intellectual disability. But also the natural environment was a really interesting one that's come out, and it was about having time and being able to enjoy being, with water or playing on the grass. And it's funny because this has not come out previously in any other quality of life tools or interviews, but it's kind of obvious, that it would be something that's important to children's quality of life. So at the moment we're trying to turn the transcripts from the interviews into a questionnaire, which will then test the psychometric properties of. So I just want to move on now, just briefly talk about the questionnaires we've developed, which is around the cerebral palsy ones. So these were developed in consultation with children and parents. They focus on wellbeing. We have child and parent report, consistent with a rights-based approach. They're freely available. We actually developed these about 13 years ago with a grant, and then haven't had any funding to do anything more with it. But being able to just kind of put it on the web, it's just really been kind of running on its own. We did the psychometric testing and showed that, you know, they were reliable and valid, and we haven't yet really, it hasn't been used enough in terms of understanding sensitivity to change yet. Because when we developed it, we tried to include everything, and then we thought we would keep coming back to it and, you know, make it shorter, but we never kind of got funding to do that. And so they're quite long, they're 60 to 70 items, which is probably why I think they're not being used so much in terms of interventions. But these are the domains that CP-QoL measures. So these are the domains that are important for children. So very similar to what I think I've been talking about before. You can see some of the kind of condition-specific domains, I suppose, around access to services, pain, family health. Some of those domains came up in our interviews and may not come up elsewhere. And so in order to ensure that the instrument measured wellbeing, these are the types of questions and rating scales that we use. So it's all around how you feel about, or how do you think your child feels about. So as I said, we haven't really done much, but it has been translated, I think, by a lot of PhD students in various countries. So yeah, we have about 24 translations now, which is great. But what we are doing now, I have a PhD student, Elena Swift, and as part of her PhD, she is going to develop a short and clinically relevant version. And really, you know, when we reflected that the interviews that we did 13 years ago, we actually need to go back to children and parents. I know there's nothing in our tool about iPads, which, you know, most of the kids are on now. So there's lots of things that I think need to be updated. But what Elena's also going to do is talk to clinicians and health professionals and find out what's important for them, because we do get a lot of requests for clinicians wanting to use it as part of their clinical practice and to guide clinical practice, but not quite sure how to do it or which domains to measure or which domains they're likely to impact on. So hopefully we can get from this a really, you know, a short 20-item, simple version. And I just kind of want to end on the quality of life discussion by just kind of highlighting that obviously we're trying to measure the quality of life of children, but the complexity of actually measuring the quality of life as children is really tough. And so I think it's just us kind of, you know, doing the best we can, but completely acknowledging just the complexity around measuring quality of life. Okay, so I now want to move on to a bit of a different topic, which is around supporting the mental health of parents of children with a disability. And I started working in this area because really from the interviews that we were doing with children and parents, children with cerebral palsy, and I could see, we then started looking at the quality of life of parents of children with cerebral palsy, and you could just see some of the mental health issues that were there and the need to explore it, and also that, yeah, as I said, this is an area that's really relatively unexplored. So I just want to acknowledge my colleagues, particularly Dr. Kim Gilson, who led a lot of this kind of background work. So we're part of a Centre of Research Excellence for Cerebral Palsy. So it gives us 5 years of funding. Across Australia, there are a number of researchers and clinicians led by paediatrician Professor Dinah Reddyhoff, to all focused on improving the lives of children with cerebral palsy. And one of our objectives is to determine how best to support carers and improve family life. And so we've started focusing on the mental health of parents, and we've really started focusing on the mental health of mothers because they tend to be the primary caregiver. But there's also such a need, and I'm kind of hoping we can then move into looking at fathers and also siblings where there's mental health issues there as well. So the way we work, we have a parent and carer engagement group, so they come together, they support us with our research, so we meet with them a few times throughout the year, we talk to them about what we're planning, what we're thinking of doing, and they share their lives with us and inspire us and help us and shape what we're doing. And they're all really passionate around supporting the mental health of mothers. So what is mental health? So mental health is a dynamic state that refers to individuals' ability to develop their potential, work productively and creatively, build strong and positive relationships with others and contribute to their community. So I really just want to highlight that I think often when people think of mental health, they think of depression, anxiety and probably more mental illness. And I think this definition is useful just to highlight that it's really around mental well-being as well. And so when we say mental health, we're actually talking mental well-being and well-being. So the reason why we're interested in this area, there's really now quite a strong evidence base demonstrating that parents of children with a disability are more likely to experience poor mental health than other parents, and particularly depression has been most studied. My colleague, Dr. Helen Burke-Taylor, for her PhD, did a study of the mental health of mothers of school-aged children with developmental disability. And so her study demonstrated that mothers reported subjective mental health 2 standard deviations below other Australians. And the mothers who tended to have the poorest mental health were those who had a preschool-aged child as well as their child with a disability, more than one child with a disability, which is not that uncommon, and also mothers of children with autism. And the autism finding has been supported by other studies as well. So just to give you some insight, I just want to share one of the stories from one of our mothers who, she's written a paper actually called The Mother Load, talking about what her life is like. So I am on a path I did not choose. My professional life as a high-functioning lawyer is a distant memory. During the last 15 years, I have felt at various times depressed, anxious, angry, and unable to cope with the demands of my life. And yes, there have been times when I have felt suicidal. Life generally with children with disability is difficult. It is hard to stay connected with family and friends, so social isolation is inevitable. I feel my world is in a slightly darker place than those who have been spared interactions with paediatric health services. You know, Susan is a particularly articulate mother, can really kind of capture how she's feeling. I work within public health and population health, and so this is a health promotion framework. So this just gives you some ideas of, strategies and where all strategies are needed across the whole level, from those that focus on individual through to those that focus on a population. But we know that if we want to have an impact on the greatest number of parents, that we're better to focus, have a more population focus. So we're particularly focused on settings and supporting environments and systems. And so for children with a disability, their parents, the obvious kind of place is around early intervention, child disability, child health services is a way of being able to capture parents and have an impact on parents' mental health. And so I think this is Susan again as well, and she really captures just the relationship between children and parents. So the paediatric health system is about children, yet to focus on improving health outcomes for my child, you also need to focus on me. The two relationships are intrinsically connected.
Definitely a better person now.
More understanding, more tolerant.
Andrew was my first. He made me a mother. He changed my identity. He's made me learn so much more than I ever would have otherwise.
I love and celebrate things now, but I never thought I would have before. After we left the hospital, it was like falling into an abyss.
I've learnt to not expect people will understand the experience that I'm going through.
You don't know where you're supposed to get help from, and then they give you a brochure to help you navigate it all.
You know what would have been really helpful? Allocating a case manager from the time of diagnosis by your specialist.
You need someone. When you first get diagnosed, your whole life changes.
It doesn't just change, it spins.
I know so many carers are limited by red tape. It's so frustrating that carers come to my house, but they're not allowed to put Peter in the bath, and they're not allowed to look after his sister, Sarah. They're quite willing to, but I can't let them because that would be breaking the rules and I might lose my care altogether.
Do they realise that in the morning I have to juggle throwing toast in, spoon feeding, all the getting ready stuff, and then as I go to walk out the door, he needs a nappy change. Toileting a 6-foot 18-year-old takes time, but he's beautiful. Beautiful child.
There are these moments of euphoric high that seem so ordinary to other people. But the contrast when you're low, it's hard to describe.
I know my husband Simon just feels like it's all about loss, his identity, his job. He feels like he's nothing now but Peter's dad. When I'm at work, I function at a really high level. I'm this wonderful, amazing person who's doing a zillion different things, but when I get home, it's so different when it's actually your family. I'm a smart, articulate woman, but I had to take an advocate to my school meetings because I couldn't talk about it, you know.
You put yourself last.
Yeah, you put yourself last.
It can take over your life at the expense of self.
The greatest challenge for me as a carer is not knowing what tomorrow will be like, not to mention anything about the future.
I find it a very emotional exercise applying for the funding, and then he's not even allocated the full funding. How can you be at school for a day without an aide for the full day? Then it's another battle to put in an appeal. More paperwork. Nobody comes out to meet your child. Nobody comes out to talk to you.
But you have to know how to work the system.
You have to tell them that things are really bad. You can never appear to be happy.
You have to know what to ask for. What I want and what can be delivered are two different things.
Sorry, we can't help you. Can we pass you on to this other service? Actually, no. We're not responsible for that. You live in the wrong catchment area. You don't want to get known as someone who complains too much.
You've got to have emotional energy and intelligence.
If you know how to play the system, you get more.
We shouldn't have to do that.
Because we end up stepping over other people.
And then you feel guilty. It's not like I don't have enough guilt as it is.
I want to take out all the brick walls that are in our way at the moment to make it a central process where you only have to tell one person your story. All the paperwork is just taken down once. Everyone shares that paperwork. You don't have to reproduce it. You don't have to pass it on. And they look at you as a whole family unit, not just your child.
Andrew has an ISP, which is a bucket of money to make his life a bit better. I'd like him to go on a respite camp so my husband and I can go away together. Then I discover that we can't spend it on council services, cabs, or respite that is subsidised. It's so frustrating. We really need a break. So we paid for it ourselves. We went to Queensland for 2 weeks. It was beautiful. There's a boat down at the marina that my husband and I discovered. We sailed up and down the river with a glass of champagne looking for crocodiles and went on it every night. It was wonderful. Getting up in the morning, I'd have a shower and get dressed and have my bathers on ready to go to the pool and think, that took me 10 minutes. I can't imagine life without my beautiful boy, and I will keep fighting for him.
So hopefully that gave you some insight into the lives of parents in 7 minutes, as much as we could. I don't think there's anything else I had planned to cover, so just want to acknowledge all the families that have been involved in our research and our funding bodies. Thank you.
There's time for questions, and I think that, please go.
Have you been able to measure the correlation between parent mental health and child QOL measures?
Yes, we have. There's not much. We have done a study looking at exactly that. The correlation wasn't very high. But actually we had parent proxy reported quality of life and parent mental health. We haven't done child self-reported quality of life and parent mental health, so that's something that we still need to do. But absolutely, and I think what we were looking at it around being a complexity around parent proxy, and that if a parent is feeling depressed, you know, if they are then judging their quality of life of their child, that you know, they're so intertwined, it's very difficult to separate those feelings.
How about siblings? Do you look at sibling quality of life measures as well?
No, I haven't. There's a bit of research around siblings' mental health showing that they're much more likely to have mental health problems. Mike might know more about them as well.
There's some efforts, but again, I think that this whole way of thinking of family-centered and siblings and larger family, whether including grandparents, is just emerging, and at the same time, the opposite. If I'm a brother or sister of a child with a disability or special health care need, there are only emerging guidelines to talk to the individuals about that. Professionally, I've experienced that the children who are the brothers and sisters, they often say, I wish I had leukemia, or I wish I had muscular dystrophy, or I wish I had autism, because they feel that their parents have had, and they don't, how would I say it? They don't regret that their parents have to do it, but they feel left out.
And certainly when we talk to parents' mental health, that's a big factor, is a feeling, you know, they feel guilty for a lot of reasons, but one of them being around not having enough time for the siblings. Yeah.
There's two political contexts in Australia. After the birth of a child, there's paid family leave for a year for both parents. Am I correct?
No.
Wait, Well, go on.
17, there's 17 weeks minimum pay.
Okay.
So, but that's just been introduced. So no, we're not like the European
Okay.
countries. We don't have any. We get a year
Sure.
maternity leave, but most of it unpaid. Yeah.
Okay. But you can't
But you
lose your
can't.
job.
No, you can't lose your
job.
job.
Okay. And then the second corollary is this National Health Insurance Disability Scheme is like, because historically, both health and community services have had waiting lists and backlogs and did not offer choice or options. This is a very important empowerment movement that the Australians are going to critically evaluate. And we should examine some components of it because there's no state in this country who says, I am going to facilitate a model of truly family-centered care where families can be both the navigators, brokers, and priority determinators. Go on here.
I was thinking about some of the differences between the U.S. and the Australian context. One similarity was dealing with bureaucratic complexity and how it rewards the parents who are good at dealing with that complexity and generates a lot of guilt among them for having to sort of game things. One thing that was also really striking was how there's a lot that's oriented around the milestones for kids up until they reach age 18. There's not much when they get older than that, and there's also not much around the milestones of the parents' lives. And so the parents really, they retire, they get married and divorced, they have to move, whatever, and there's nothing, those are not acknowledged as legitimate issues that the caregiving system is supposed to be dealing with. It's about the child who has condition X, not about mom who's taking care of the child with condition X. And that is very, and that's when they really feel like they're giving up their lives for their kids because they can't have their own life is not acknowledged as part of what needs to be attended to.
Absolutely. Yeah, I agree. Completely.
One other thing was that a lot of them were being injured by their adult sons when this was Fragile X sample, and that also generated tremendous mental health and well-being issues. About a third of the parents the moms had some level of being injured by their sons.
I did an interview just the other day, and the mother sat down. And she knew I was talking to her about her mental health, and when she, took off her jacket and showed me, and she had bruises all over her, and scratches on her neck, and bruises all over her arms. And she had a 5-year-old with autism who has outbursts, and she was like, "This is my mental health." So it's a massive issue.
What can they do for those parents that would help deal with those kinds of behavioral issues?
Well, I think that's probably more an issue for pediatrics in terms of dealing with the behavioural issues.
It's, the real hard thing is that we don't really have a system of child behavioral health that's proactive and supportive and has capacity. In fact, that there's so many things that are fragmented is why both the parents' movement and efforts of individuals have called for equity in it. The closest thing that comes to equity and behavioral health is, the Wellstone Act, and we still have a while to go upon implementing that.
Just on what
I
you
mean-
mentioned, sorry.
Yeah. The other thing is, if you really look at it, there are times that disproportionately the caregivers in the course of being a caregiver for 2 decades for their child, they gain 30 years in terms of whatever we want to call biological or stress life or allostatic load or however way you want to determine it. And that has an impact on both their physical health as well as their behavioral and social health. And we're really, it's kind of really crazy to not really say, what does it take? We would never force a family to make a decision. Either you stay in the hospital with your child or you go at home and you feed the other kids. But that's exactly what we do in some of these, we're saying, do you want a home, but we can only give you electricity we can't give you water, we can't give you plumbing. And it's pretty dismal at times.
And we've kind of found as well that parents of older children, I think, they have so many negative experiences along the way. So those with kind of adolescents, they just kind of disengage from services as well because they've had every possible experience happen, and they've fought so much. That's what I say to us, they're always fighting for services and they just get fed up, which is a challenge in itself.
I was surprised to see the percentage who did talk about mental illness with general practitioner or psychologists and psychiatrists compared to the sort of American context of psychologists and psychiatrists. And I was pretty surprised. I don't know if you got any insights to the role of potentially clinical social workers. And I don't know if that is different in Australia.
Yeah, so our system is a bit different. So for parents, they can go to their doctor and they can say that they're struggling with their mental health and they get a referral which will give them, covered by Medicare, so the public health system, will give them 6 sessions with a psychologist. And so that's kind of the pathway that they'd be advised to go, or psychiatrist if they're needing medication as well, although the doctor can give medication too. Most of the disability services providers, they have social workers. So like say Urella has 3 or 4 social workers that parents can connect into. So we do use social workers as well, but if we're talking around mental health problems, then it would be psychologists or psychiatrists.
So they don't provide direct counseling that's reimbursed by the system?
The social worker could. The social worker could provide counselling to parents, but if there'd be a certain role the social worker takes on, and then if they felt that it was moving towards mental health issues, then they would refer to the doctor and psychologist and back down that path. Yeah.
Those social workers have many skills to do this. The tendency over time, at least for hospital-based social workers, and this has been as medicine has become more complex, is they really focus only on 2 things. They focus to the family, have the transportation to come and visit, and do they have a place to go home? There is not enough, like you have one social worker for a cancer center where, hundreds of families are struggling with death and dying. It's like, it's so under-resourced for the complexity of need. And we don't have good models to clone that need. It's like saying I have one chaplain for everybody in the entire hospital. That ideally it's better than not having none, but it's not adequate to the task.
And I think for us as well, a lot of social workers have been cut back. So that's kind of one of the first things that goes, when everything's tight.
Yeah, I noticed you were using mothers and parents interchangeably. So that led me to wonder how many fathers responded in the survey or were involved in interviews at all. And that also led to another question of, I don't know if you found differences from what you learned about single parent versus co-parenting certain situations.
Yeah.
And even,
So that, the first study, which was around the quantitative and qualitative, so that was actually just focused on mothers.
Okay.
So where I'm referring to parents is probably where we're going now in terms of an intervention that is open to everyone. But a lot of that background work is around mothers. But we haven't yet looked. We thought that we might have, a higher percentage of single mothers in our group, but we didn't. There was still about 90% of them were married, which was kind of consistent with population levels. So we haven't looked at that specific, but it wouldn't be a big sample either of single mothers.
So are mothers the ones that are interfacing with the health system and the social services?
Yeah, so mothers tend to be the primary caregiver. They tend to be the one going to health professional appointments. But as I said, I don't think there's anyone doing research on fathers. It's a massive issue. And what mothers are talking to us often is they're having to cope as well with the father having mental health issues around dealing with childhood disability. So, it's also another layer for mothers, but definitely there's a need to look at fathers. And I think it kind of needs to be done in a similar way where you start with a group of fathers. It really needs to be led by a father as well, and obviously different strategies. Some service providers have, little fathers groups and things where they might get together for a drink or a barbecue or something. And they find that that's quite effective in that fathers will slowly start talking about some of the issues and find it useful to connect with other dads. But traditionally they don't have the opportunity to connect with other dads.
So the surveys that you received, did it talk about specific types of services that parents were receiving and how that might affect the well-being of parents and mothers?
So services that mothers were receiving?
Right. Services that the child.
That the child was receiving. Yeah. So look, they normally, because of the range of disabilities, they're normally seeing all, physio, speech therapists, occupational therapists. We actually have a model though, for the younger children, it's called a key worker model, early intervention model. I'm not sure whether you have something like this, but so if you have a child who has developmental delay, then they get kind of taken up by a service provider. They have someone who comes out who has a particular background, speech, OT or physio, probably most aligned to that disability, and they go and visit the parents every fortnight. For 1 hour, there's funding for them to support them, give them specific strategies and advice. So that's kind of how our model works. But from our partnership project with Urala, when we talk to parents about mental health, actually not a lot comes out of it. Like, they're kind of very satisfied with the services their child is receiving. The difficulty is accessing those services and being able to navigate the system, but generally the services they're actually getting, they're very happy with.
Lucy, do you want to? Lucy's looked at waiting lists and stressors on families and some of the complex systems, especially for children with autism.
Yes. And thank you. Your talk was very interesting, and the film, I'm so glad you did it. I think that was a very powerful 7 minutes, and I think not something I'd seen before, so I think that was really effective. Just to piggyback on the last question, I guess, so the early intervention, the system you were just describing, that kind of early intervention model in Australia goes to what age?
To 6.
Oh, that does go to 6, so that's 3 years more than we have.
Okay.
So that's positive. And I guess one other question that I had, an area that I've been doing a little bit of work in and trying to move further is actually the intersection of childhood disability and the child welfare system. Mm-hmm. And so I wonder, the last part of your talk where you were introducing the work you're doing on parents' mental health made me think, wow, that should be completely relevant to, I assume, many foster parents or adoptive parents of foster children, with or without disabilities, because it explicitly defined disabilities the way we're talking about it. Is there any, has any of your work sort of looked at how children with disabilities in the child welfare system have fared, or any of these ideas, how that has related to the child welfare system in Australia?
Look, we haven't. I don't think we've really had the numbers. Like we do, we look at who the primary caregiver is and whether it's a biological mother or a foster parent or grandparent or whatever, but we haven't really had enough numbers. We've not done anything dedicated specifically. But it's definitely an area that is needed.
It'll be interesting to see the kind of interventions that you're developing and thinking about that moving forward for other sets of parents.
Absolutely, yeah.
Well, thank you very much.
There's one.
Oh, I'm sorry, I didn't see it.
Okay.
Excuse me.
I was just curious about what, like, the societal and cultural values are of, like, two things, of, like, mental health and talking about behavioral health issues, and then also around parenting and child rearing in Australia.
So we have we've had a big mental health campaign, which is that 1 in 5 people have a mental health problem. Do you have that here? No? You don't know 1 in 5? Okay.
We have 1 in 5 people with mental health problems, we just don't have any.
We don't want to acknowledge it.
So we've tried to do that. There's been lots of ads on telly, you know, creating awareness around that. Also around employment, we've had a lot of issues around employment and mental health, so showing that people can be treated for a mental illness and then they can return to work. So there's been kind of trying to, yes.
The concept of mental health and
yes.
that we should strive more for like mental well-being and explore different ways versus there is something wrong with you versus what's going on.
Exactly, and also trying to say it's a mental health problem, it's a physical health problem, they're equal, they're not, you know, it's not controllable.
Cared for, and
yep.
you should have access to a healthcare provider to help you.
Yes, so there is that, but there's also, I think, when you then look at mothers, the expectation that if you're a mother caring for a child, you would need a certain level of mental health to be able to do that properly. And so I think that's where some of the stigma comes around about being able to say, I have a mental health problem, I'm not coping, and what that means for the care of the children.
Do you feel like, so with the part about like, what are the societal and cultural values of parenting and child rearing in Australia? I know that in a lot of communities in the United States, people are more mobile, so the chances that you live in the community that maybe you were raised in and have familial relations that can help provide different levels of support, whether it's emotional support or, you know, taking the child for 2 hours so that you can take a mental break. And then just the concept of kind of like, it is so important here in a lot of parts of the United States that you put all of your resources into your children and that you almost like sacrifice things in order to, you know, to better your child. And so when you have a disability on top of that, or you have something that's going on with your child, it's kind of like the expectation that you should just be really giving at the expense of your own health because your child is so important.
Yes, I think that would be exactly the same, and that's what we hear mothers saying, that they do put themselves last. What was the first
And then
one?
it's like the expectation that society thinks that that's okay.
Yes.
To do that.
Yes, absolutely. And also I think that, you know, that when you go to our maternal and child health system, that you're kind of, if you've just had a baby, you're taught to draw on your networks around having a break and how important that is. So yeah, I think there's quite a lot of similarity actually in terms of that, and I think there's also, you know, that kind of drive that you would do as much as you can to support your child, and so, you know, you would fight for any type of intervention they need to support them. So I think there are a whole lot of pressures actually on families for that. Yeah.
Thank our speaker.
Thank you.